government, and a group called the Advisory Committee on Insurance Immunization Practices. RFK Jr. fired all the members and reconstituted the committee with mostly vaccine skeptics. And so states have been taking things into their own hands. And so we have Mrs. Shelley Fine for co-chair of the committee. And so the first item on our agenda is to hear about a bill in the state legislature that has been sponsored by our state senator, Brett Holmes Siegel, and our assembly member, Michael Lasher. And we have a representative from Brad's office, Jonathan Weinberg, who's, I think, senior legislative counsel. So he's going to tell us about the bill. So Jonathan.
Thank you so much for that introduction, and go Yankees to those of you who are going to be watching the rest of the game after this meeting. For those of you who are bitter about the Mets collapse, I'm sorry for your loss, but we're here for a more important matter today, and that's preserving vaccine access in New York State. So that introduction did an overview of the lay of the land far better than I ever could, but in short, the CDC has for decades, impartially, safely, and consistently with science, recommended vaccine schedules through the ACIP, the Federal Advisory Committee on Immunization Practices, longstanding, highly regarded, historically consisted of experts, bipartisan, non-controversial, and for that reason, in several respects, New York law has deferred to that ACIP body with respect to immunization schedules. There was nothing short of a coup by the current secretary, Robert F. Kennedy, who completely reshaped that committee with unqualified hacks and skeptics. And as a result, as many of you saw these past months, they've made a number of improper, contrary to science recommendations, most clearly with respect to the COVID-19 vaccine, which in previous years, boosters have been recommended for individuals irrespective of any pre-existing health conditions. And so persistent with that authority, New York pharmacies and medical providers have been able to administer the COVID-19 booster shots to individuals who wish to receive them, consistent with recommendations year after year. The last month, when the ACIP, contrary to science, failed to recommend the COVID-19 booster to individuals under the age of 65 without a pre-existing health condition, New York pharmacies were temporarily flustered and in flux. And because of the way the New York law is written, they argued that they could not administer vaccines at their pharmacy locations from pharmacists unless an individual was over the age of 65 or had a patient-specific order. And so, along with Assemblymember Lasher, we jumped on this opportunity to try to address this gap in the law, and we did our research. And what we found was that the scope of practice for pharmacists under New York state law, and this is at education law. The education law addresses scope of practice for various professionals, including pharmacists. Education law 6801 sets out the scope of practice for pharmacy. And in that, it addresses immunization. And it specifically authorizes pharmacists in the state to administer immunizations according to recommendations from the ACIP or with patient-specific orders, if that prescriptions from doctors. So in other words, under the current state New York law, pharmacists can only administer vaccines to the extent that they're recommended by ACIP generally, or if a patient goes and gets a prescription from their medical provider. That's untenable and, again, contrary, and under normal circumstances would have been fine, but in this modern Trump environment with this HHS, with Secretary Kennedy and the hack ACIP, it's resulted in New York, unfortunately, being hamstrung in its ability to offer vaccines consistent with scientific recommendations. And so our bill, as it currently stands, amends that statute, and it would allow specifically for pharmacies, or the scope of practice for pharmacies in New York to be extended, that pharmacists would be able to administer vaccines consistent to recommendations made by ACIP, or in the alternative, recommendations made by the Commissioner of the Health regarding vaccines that have been authorized by the FDA. So if the FDA says a vaccine is authorized in some capacity, the Commissioner of Health would have the authority to constitute a New York analysis and make a New York determination to set a New York vaccine schedule for pharmacists. The bill goes on to also address the publication of pharmacy schedules, to allow for pharmacies to display the schedule to reflect the recommendations made by the state in addition to those made by the federal government. And then in third part, addresses the only other instance under New York state law where currently scope of practice is restricted expressly with respect to CDC recommendations, and that's with respect to the meningitis vaccine. Currently under New York state law, the meningitis vaccine can only be administered as recommended by ACIP. We would remove and strike that reference to allow the State Department of Health to make its own determinations as to the meningitis vaccine. Now, there are other areas of law in New York where the ACIP is referenced, but its recommendations are not dispositive. And so with respect to physicians and nurse practitioners, the law, the state law allows them to administer the COVID-19 vaccine expressly as a matter of statute, along with the other standard vaccines, and then says, in addition to those vaccines, you can also administer vaccines recommended by ACIP. We are considering also amending those statutes as well, just to make clear that the state can make its own alternative recommendations. But again, right now, in the here and now, in this current emergency, we focus the bill on making sure that the COVID-19 vaccine can be administered without a patient-specific order in as many places where New Yorkers interact with healthcare providers as possible, and that current gap is in pharmacies. Just so you all know, and to address any confusion as well, pharmacies are temporarily allowed to administer the vaccine because of an executive order issued by the governor. It's Executive Order number 52. And so she's issued that emergency or executive order to allow pharmacies to temporarily administer the COVID-19 vaccine. However, that has to get renewed every month and is temporary. And it's important to have a permanent statutory fix, hence why Assemblymember Lasher and Senator Hoyland-Siegel have introduced our bill. The bill number, for those of you who want to look it up at home, is S7823A. So again, in short, just to recap, and then we'll open up the Q&A. When the Trump HHS had a coup at the ACIP and failed to recommend the COVID-19 vaccine booster consistent with science and consistent with past practice, pharmacies in New York were temporarily hamstrung in their ability to offer it to anyone who wished to receive that booster. The governor's executive order temporarily has allowed pharmacies to administer that vaccine, and our bill would allow them to permanently administer that vaccine so long as it would be recommended by the Commissioner of Health, consistent with scientific practice. And with that long introduction, I will open it up to any questions.
Thanks, Jonathan. You broke up there for a little bit. We missed maybe a couple of sentences, but I think we got most of what we needed. Questions?
What is the timeline? It has to get passed through the next session.
Very good question. We believe this is an emergency, and so in the event that there was a special session called by the governor to address this and other issues, we would make it a top priority to pass in the special section. But otherwise, the legislature will not be convened until January. As I think all of you in this room know, the senator is very likely going to become the next Manhattan Borough president, in which case he would vacate his seat and the bill would be reassigned, but we would be working with the Senate Majority Leader to ensure the bill finds a sponsor who would advocate for its passage as soon as possible once the legislature convenes in January.
Is there urgency that it be done before January, or does the governor's order cover things till January?
So the governor has made it clear that she's going to extend her executive order monthly through the calendar year at the very least, and probably into the next calendar year until this can pass. So we don't anticipate any challenges to her executive authority. It's consistent with the COVID-19 emergency and similar orders issued by her and the previous governor and governors in other states. So listen, I'm a risk-averse lawyer. I like certainty and I like permanence, and so my recommendation will be to pass it, as soon as possible. But practically speaking, with 95% certainty, the vaccine will be continued to be offered in pharmacies until the statute is passed, pursuant to a recurringly renewed executive order.
Other questions?
Are the pharmacists and NB organizations, are they pushing for the legislation? Do they feel that the executive order covers them?
Yes. So we did consult with pharmacy groups when we drafted our bill, and they did approve the language. They are also offering the vaccine consistent with the executive order. So in short, that there doesn't seem to be any doubt right now that pharmacies can offer the vaccine pursuant to the EO. The pharmacies mostly seem to be consistent with that, especially the larger pharmacies. Now, some of the smaller, anecdotally, I've read there's some smaller chains that I think are mom and pop type pharmacies that are confused, and I know there's trade groups that help them out, but there seems to be some confusion there. But hopefully that'll get addressed, and the bill would definitely is, as far as we've been told, supported by the pharmacy groups that we've consulted with.
Maybe something should be added to it. Maybe an infomercial on radio and.
So I think we lost the audio from the room, or at least I did. I don't know if you guys can hear me.
Online, I can hear you.
Yeah.
I can stand on my head.
That owl may not be plugged in.
You guys are back on now.
Oh, okay,
Yeah.
great.
So my point is, I think there should be an infomercial as a part of the bill required, because most people have no.
We just lost the room again after there should be an infomercial.
I think while they're sorting through that, just quickly, has there been an anticipation of how the federal government may reply? And is there consideration of potential actions?
It's a very good question. We have not heard a response from the federal government. This is a rare one where I don't think that there would be an opportunity for the federal government to intervene. It's definitely within the purview of the state. There's no preemptive force with respect to HHS and vaccines. In other areas, there's a much stronger preemption argument when the state tries to do something contrary to the federal government, but this expands and doesn't entrench upon ACIP. And so, we've seen in other respects the federal government threatening to withhold money from states when they take, or cities when they take certain actions. Just this week, the federal government threatened to withhold money from the New York City school system unless it instituted a bathroom ban. We haven't seen anything like that in response to states taking preventative and expansive measures with respect to vaccines, but we are monitoring.
Try again.
Try again.
Tell me if you can hear me. Can you hear me?
That we can hear.
Okay. Everyone knows what the federal government did, but most people don't know what the state government has done, either in the executive order or in this bill. I think there should be something in the bill requiring infomercials on TV and radio to inform people what their rights are and what their opportunities are. In addition, I rarely, if ever, have seen this year any placard, any sign in any drugstore, pharmacy, and so on, to indicate that it's available.
Right. Yes.
And I think that's very serious because if people think that everyone's telling me, well, we can't do it anymore because of Trump, because of RFK. But now if we can, we need to let people know.
That's a really, really good point. We at the minimum, I would want to raise that with the DOH as soon as possible. Because listen, if it's, this committee is, some of the most knowledgeable people in the city, right? And so if you are the ones coming to us and saying, listen, we are hearing that people don't know this, that's really important to hear. And so I'm going to take that back to the senator. And at a minimum, I think, we'll definitely want to escalate this to the Commissioner of Health and really strongly advocate for a public awareness campaign, at the very least, some sort of letter to the Department of Health. But that's a really strong point and important one.
Roberta?
Yeah, I think it's a very good point. And additionally, the cost. So the big concern is seniors 65 and over know that Medicare will pay for it, but other groups are unsure what insurance covers it, whether Medicaid covers it, whether their insurance covers it. So, if there's a bulletin going out, it should include who's covering it. And if not, maybe, like the electeds did during the COVID pandemic, offer free shots.
Oh, yeah.
That's a really good point. And I also find that gets lost a lot. The Department of Financial Services, which regulates the insurance industry in New York, issued a circular letter to all insurers in New York on September 10, advising them that it's the position of the state that they are required to cover the vaccine, or sorry, not required, they should use the word strongly encouraged to cover the vaccine under current state law. So that's something we should definitely signal boost and encourage the state signal boost as well.
Thank you.
Jonathan, how does this mesh with the new collaborative of the Eastern States, Public Health Collaborative?
Really good question. So our belief is that the bill would allow the collaborative's recommendations to then be adopted by the Commissioner of Health under the bill. So we wrote it in a permissive way, rather than being too prescriptive for how the Commissioner of Health makes that recommendation. So the way we think it should work in practice is the collaborative, gets together, makes some recommendations, and then the Commissioner of Health formally adopts them for New York.
Other questions? Okay. At some point, I think I want to make a motion to pass a resolution in support of this. And we actually have some members who are going to have to leave around 7:30, 7:45. So
Sounds like we lost the room again.
Active communication and explanation about costs.
right. Can you hear us now?
Second the motion.
Can you hear us now?
No.
Yes.
Yes,
They can't.
they can.
They can't. Okay. All right. Are you seconding the motion?
Second motion, including the communication and the.
We unfortunately lost the room again.
Yeah, Jonathan, just for your knowledge, unfortunately, that it does drop from time to time. So it's
Who is our internet?
You're back.
no an issue. Sorry.
Can you hear us?
We need to.
We're trying to
Now
pass
we
a
can-
Why don't we call the question?
Hold on, I want them to be able to hear us.
we can hear you now.
Okay,
We can hear
so
you.
the resolution is just essentially going to have a bunch of whereases about what's been happening and the need for this bill, and then
No, it
it's
doesn't,
gonna say we
whereas
support the
the
bill.
following facts were taken into consideration,
Yes,
so we
Yeah.
don't do it whereas.
well,
Right, no, we're, right.
I know how to write. So anyway, and then we're gonna support this.
Yes.
Right.
So
Yes.
all
Unless
in
there's
favor?
someone who doesn't support.
Aye.
Eight?
Sure, I'd like to, I mean, I thought we would have a little bit more discussion, to be quite frank.
Oh, well,
And
we
Yeah.
can have more
I don't know if
You wanna
now,
ask me?
the resolution seems fine, I just think that the messaging should probably be devoid of less editorial and more fact-based. I
Okay,
think we're in a very dangerous
Mhm.
time, and how calling federal hacks is not really the
I don't
right,
think
the
that's
right
in the
thing.
bill.
I know, but I think it's important, I don't want
Have to say it.
political rhetoric anymore, I don't want hateful words, I want fact-based words. There's a lot of information about mRNA vaccines too, about this particular vaccine. This is not mandated schedule, it's a different type of vaccine, if you really dig deep of what it is. So I just think it's important to.
But MMRV is not on this, it's not on ACIP either. So
Yeah,
that's,
yes,
that's
but-
not on, that is not a part of the
Yes.
ACIP recommendations.
but
That's,
the-
no, but see, what you're doing
Yeah.
is you're going after, you're pulling on the facts that anti-vaxxers like to
No,
harp
I'm
on.
actually,
But MMRV is not even on the
I said
schedule,
I
so
had a
there's
problem
no
with-
debate about
I
MMRV.
said it's a particular type of vaccine that's a little different, that has some,
Right, but this is about
contradicted-
COVID, this is about COVID, not about MMRV.
I know it's about COVID. So,
You're concerned about
thank
the
you.
language?
I just thought the language was just inflammatory, and I'd like to, I
I can assure you
Yes.
that
I appreciate that, I read it, I just think it's important that, you know, as leaders, that we also, you know, I want to create better discourse, I want to create a better, whatever, and just because I have an opinion, it's also true to be sort of attacked, but it's a little bit bizarre. I would like to
Bizarre,
add-
you talked about MMRV, we're talking about
No.
COVID, so you were trying to move
well,
the
this
debate.
this
No,
away
no,
is
from-
actually,
about more than COVID.
No, it's not.
The main
And
point
MNRA
you're making about
I was
this-
talking about a
Isn't
different
the bill
vaccine,
about, I know,
I
but isn't the bill, just to clarify, isn't the
I may
bill
have
about?
misspoke.
Hold on.
No, you
one-
didn't
one
misspoke, you
person.
spoke about MMRV,
No,
but
I actually,
but the
I may
bill
have
was-
specific MRA vaccine, it's just that
there's no.
I just think we should just take out words like
Yeah,
and those things when we're talking about, we can all have opinions about what we believe, but I'd like to demonstrate just a little bit better. I
Yeah,
think we've seen some
okay.
pretty scary things in the last 2 weeks, and
Yeah.
I'd like better.
so
for
if
for
you,
us.
so if you
Your
had,
point
Yeah.
is well taken.
I'm
Yeah.
gonna be,
Thank
I
you.
and Saralee are gonna be writing
Yeah.
the resolution,
Yeah.
so
Yeah.
if you had our assurances that we're not gonna be using.
Sure, but I'd like
these
to talk
as
about the resolutions, I'd like to, you know, the resolution, we can review it, we can talk about it, you know, I think,
Yeah.
yeah, it sounds great, but I would like that the PSA, which is critically important, I worked for the health department for a number of years, is important that it be presented without inflammatory language, so that people can make their own decisions. And that, you know, that we feel, you know, that's the right tone we want to set.
So, okay, so we have 9, I think, in favor, so all opposed?
Well, but what, did you count the people?
Well, we have Michael, right?
Right,
And
and
Will.
then also, Will.
Will's not on the committee.
Sorry, I didn't see.
Which is separate
Oh, he's on.
call for.
No, we just lost. Will, did you vote for this? In favor?
Yeah, I voted in favor for it.
Okay, so that's 11.
He said he will.
You will, okay, well, okay. So all opposed? All abstaining? All not voting for the cause? You're not gonna vote at all?
No, I
You support it?
support this.
Yeah. Oh.
You added me.
Oh, I know.
You added me, yep.
I didn't know I
Yep,
could.
you added me into your
Okay.
merit.
Okay.
Yeah.
Okay, so Jonathan passed unanimously.
So,
Um,
since
and-
nothing can be done
Is it
until
12,000?
January.
12,000?
Right.
Yeah.
Since nothing is gonna be done until January, do we need to do it like instantly? I just want to know the time. Yeah.
I think you should.
I think.
And I think it's good if we do, because people become aware of it.
Yeah, it's good to be aware of it, but the PSA should be it. It should be for every New Yorker.
Right, okay.
So, so now we also have a representative from Assembly Member Linda Rosenthal's office, Zach Binder, and she has a couple of bills that I just heard about 2 hours ago. One of them is called the RFK Act or something. So Zach, you want to tell us about what Linda's been doing?
Sure. Hi, everyone. It's great to be with you all. I'm going to give a brief overview of some of the bills we've been working on in response to vaccines, medical mis and disinformation. And so to begin, the Assembly member wrote 2 letters to Governor Hochul asking that she issue non-patient specific standing orders for the COVID vaccine. And on September 3rd, Governor Hochul signed that executive order that Jonathan was talking about that allowed New York State pharmacists to administer the COVID vaccine. And we have written another letter urging her to do the same for the MMRV vaccines and the hepatitis B vaccine. And as you mentioned, we also have legislation called the RFK Act, the Refuting False Knowledge Act, which goes to a point that was mentioned earlier about communication, which instructs the New York State Department of Health to create a board of medical providers and experts that would be tasked with combating the growing threat of misinformation. And it'll consist of experts who are appointed by the governor and the leaders of both houses, and will serve 4-year terms. And their responsibilities will be to create best practice guidelines for communicating factual and reliable medical information to state agencies and to the public, including both rapid responses as recommendations change from the federal government. And it would also help craft media literacy resources, both for online and in print, to help people digest all the information that's on social media about vaccines, abortion pills, and the like. Additionally, we have another bill in the works that extends liability protections to vaccine providers. So this will work in tandem with Assemblymember Lasher and Senator Hoylman-Siegel's bill, and it will ensure that medical professionals who administer state-recommended vaccines are protected under New York State law in the same way that they are now when they administer vaccines recommended by the ACIP. Additionally, we have legislation that would expand insurance coverage. It would require health insurers to cover any vaccines that would ultimately be recommended again by the State Department of Health. And this is all assuming that states will start recommending their own guidelines and vaccines. And so we need to have the infrastructure ready when that happens. And lastly, we have a bill that is a few years old, but was introduced at the height of the COVID pandemic. It's A3082, and it requires the instruction of vaccine science in every middle and high school in the state. It would be in the health curriculum, and it would include vaccine history and development, the effects of vaccines on the immune system, information on vaccine preventable diseases, and also on safety and testing for those vaccines. And we note that also a dozen states already have this type of legislation as a part of their school curriculum. And we think that getting this information to young people is really crucial, especially now when there's so much mis and disinformation on the internet. And so those are a few things that we've been working on. Happy to take any notes or comments back to the Assembly member. This is only my second week as legislative aide, so with respect to answering questions, I'm not sure how much I can do at the moment, but I'm happy to bring them back to the Assembly member. Thank you for your time.
Thank you, Zach. I have a question on the third one, on the coverage one. Why is that necessary? I thought that Jonathan's or Brad's bill would take care of that. Like what gap does Linda's bill fill?
So there very well might be some overlap as these bills are sort of being developed in response to the same things at the same time. So it very well might be covered in Brad's bill. But as far as the gap that it's filling, I'm not really equipped to answer that at the moment.
Okay, I understand. Other questions? Yes.
A timeline on this.
Yes, so the timeline is the same as the other bill. Senate doesn't, I mean, the session doesn't start until January. That's why we've put some emphasis on these letters to the governor, because if she were to issue non-patient specific standing orders for the other vaccines that are in jeopardy, we could potentially have those ready if they're, no longer recommended.
So did you want a resolution from us?
I don't believe we wanted a resolution. I'm just here to let you guys know everything that we're working on. But I don't think a resolution is necessary tonight.
Perfect.
Yeah, I think we need to
Yeah,
actually read the bills.
We need to read the bills.
Yeah.
Yeah, of course. I can send them over after this meeting.
Great. Michael, did you have a question?
Yeah, question, comment. One thing I just wanted to bring up, and Zach, congrats on it sounds like the new job maybe. One thing I think you were talking about was, this is an opportunity for New York State to put in experts to start to say like what the truth is. I think we're seeing that at different levels of government, and the issue that we're running into is that different levels and different political parties are disagreeing on what that is. I personally, I think, I'm in agreement with everything that's sort of being advocated for here. But I think it's just worth caution. I think it kind of goes back to the point that was being discussed at the table just before the vote on the resolution previously, which is just that this, the rhetoric is sort of, certainly charged. And I just think that, maybe this government should not be in the business of telling us what the truth is. And just more like creating the spaces for us to, to work with people in those fields. Like I would talk to my doctor. I don't need the government to tell me to talk to my doctor. I don't know, maybe that's just a personal thing. I don't know if that's going to change, my own personal take here is going to change anything with this process, but I think it's just worthwhile in considering, the status quo on things right now can change at any moment, and someone's definition of truth can change to fit their political needs at any moment. Parties that are in power can change. So that's my only hesitancy with stuff like this, which is just that, you feel good about it when the people that you support are the ones who are advocating for these positions, but that there's not that constancy, you can't rely on that always. And so that's why I'm just the only bit of hesitation there. Again, I don't know if that's something that you can address, but just a thought.
Yeah, absolutely. I totally understand what you're saying, and I hear you. I think that the kind of crux of this bill is actually the person who is reading medical information, having the resources to kind of do their own research, or both kind of absorb what's out there and figure out how you go about kind of taking in evidence and thinking through these things, because there's so much information. And so kind of creating these guidelines, not telling you what to think, but kind of giving you the resources and guidelines for what would be the right approach to thinking through these things, as well as having, a group of experts who are able to direct other agencies with how to communicate. I think it's obviously a really hard issue, tackling mis and disinformation, especially on the internet. I know that also we've seen over the last couple of years, social media companies roll back fact checking and roll back for more of like a community oriented approach. And so these are all the challenges that we're facing. And we just think that having, because the ACIP has now been replaced with majority vaccine skeptics, it's important at the state level to have some body where there are people who are kind of sticking to science and evidence, and at least providing resources for people to have when they want to assess information. But I will definitely bring that point back to the assembly member.
My personal recommendation to the assembly member who I have the highest, greatest respect for, and in whose office I had my flu shot the other day, if you recall, that she removed the title RFK bill. It's really wrong in so many ways in terms of not focusing on what we need to know, okay? And two, it's RFK Junior that she has a problem with. I'm sure she loved RFK. A better name for the bill, and if she needs, I'm sure she doesn't need any help, she has great staff. I'd be glad to suggest one.
You
I
don't have a
agree
response,
with
Bill?
Shelley. I agree too.
Yeah.
Okay, I'll bring that back to her and definitely let her know.
I have
You
just
guys.
one last comment. I loved the idea of the curriculum for high school and middle school students. I think it's so powerful and important. And I also think, you know, if you could articulate, you know, there are, you call them skeptics, and I think all of us should be you know, we all should be skeptics when you go into your medical care, because you should take responsibility to learn. And so, you know, the high school, middle school students will want to approach this in what can I learn and how much, you know, what good decisions can I make because I'm better informed. And if you build a curriculum that has, you know, a very nonpartisan or multiple type of perspectives that are feeding into a particular curriculum, to be able to, you know, present different types. And I didn't speak earlier, but my point is there's different types of vaccines. And I know because I have some familiarity with the scientific patent process of vaccines, and the COVID vaccine works differently than the flu vaccine. They work very differently, and it has different effects on your body. And it's important for the consumer and for the high school student, middle school student to understand how that, you know, and the side effects that come from one versus the other. More information is not something we should fear. We should all approach, you know, and we should ask our leaders. Public health also should play a very important role in, you know, you should be able to look to your public health institutions to say, this should be a best practice that's informed by experts, but balanced experts. And so taking out the rhetoric, of course, I would completely support that, but also just demonstrating a structural integration of different perspectives, because if you have any scientific background or knowledge, you will know there are multiple different ways to look at data sets. We all know that, from whether you're an economist.
I'm sorry, wait, stop a second.
We don't know.
Because that's really important. First of all, I'm not sure about a curriculum, because what's happening now in many schools are they're changing the curriculum. They're taking out curriculums that have been there for the last 50 years.
Yeah, I love adding something
inserting
health-based. I think it's great to talk about the science of vaccines.
If you talk about the science of vaccines, are you talking about the science of it, or are you talking about
The science of vaccines, yeah.
I'm talking about the history of
Yeah.
it and what has been successful. And
I
I
probably do all of it.
and I
Yeah.
think
We're
that
not deciding what's going on.
Yeah, no, I just think it's a great idea to have, you know, to have a bipartisan or multiple experts feed in. It's a great best practice. It's a great
this is
best
the problem that
practice.
the CDC has been ruined, because before that, you did have a best practices, the best in the country, the best that was validating certain
But
things.
New
And we
York never
don't
had
have
it.
that anymore.
But New York State never had it curriculum.
Right.
No, I
So
think it's
kids
great.
going through junior
Yeah.
high and high school in New York
I
State
think they
have
should
never
know.
had.
I did, I mean, what did,
No, I don't think we
I
had
went
a
to school in
scientific
New York.
curriculum.
We did,
No,
we
Yeah.
did.
We did not,
Thank
there were
you.
no vaccines when.
we did.
No, when we
No,
went to
science,
school.
the history of science and whatever we did.
I
But
think this is a
the
little.
thing is
different.
that
there was no curriculum in New York State.
Okay. Okay, but the thing is, if you have, well, there's this vaccine and that one may give you the list of side effects that you get on TV every day. And this one may have this kind of side effects. And this one,
Terrible, yeah.
somehow or other, you were losing the effect of the vaccine with,
I believe in the power of the
sounds a little
individual to
muddled
have, I believe in in Americans, I believe in New Yorkers, to have more information is better information. I believe in competence.
But
and I
we're
think
also
I think
not
it's great.
creating the
Yeah.
curriculum.
Yeah, no, of course.
I didn't
My
believe
point
in
is that
American
create a curriculum that someone can look at and say, this is not, this is worth something because it's had different levels of
Nothing's been
input
going
and it's
ahead anyway.
science-based, agnostic of opinion, you know, it'd be great.
So I think
Yeah.
we,
Yeah.
we've
Yeah,
beaten that one.
we got there.
Thank
I
you.
had to say,
Thanks,
No
Zach.
FDR or our.
RFK.
Thank you, guys. I'll definitely bring all those comments back to the assembly member. Thank you.
Tell her we
A
love
lot-
her
a lot to
anyway.
tell
It's
you.
a tender
Um,
subject.
Yeah, and so are we finished? Zach, any other questions for Zach?
No.
Well, thank you, Zach. We now have you might want to stick around. We have speaking of curriculum and teaching about vaccines, we have a physician who's going to be talking to us about vaccines.
It's actually about vaccine skepticism. So,
About vaccine skepticism, but also it includes kind of a primer, at least last time I looked at it, about vaccines and what's recommended. And Michael, you should pay attention because he talks about babies. What they should do.
I'm already following the schedule. They don't got to convince me.
Okay.
all right.
Good for you.
Oh, so thank you,
Good.
Zach. And
Um,
so this is Michael Cantor, MD,
yes.
who is a public member of our committee. And he has a PowerPoint presentation.
Just give me a background for the tape.
Oh, yes. So I work at Bellevue, internal medicine 1 day a week. I also work for Regeneron, which is a drug company, but we don't make vaccines, so I don't have any conflict of interest. And my background is biomedical informatics. I've been practicing at Bellevue for over 20 years. And let me talk about vaccines. So this is just a slide of kind of what changed. So these are all the recommended adult vaccines that are from the CDC. This is 2024 before the most recent meeting. And the next is what happened. And you'll see there's a very slight change in this one, which is that pregnancy is now gray. So COVID, that was one of the recommendations that the current ACIP took out, was a recommendation of COVID-19 being given to pregnant women. And he also part of the, and what we just heard was about, people over 65, et cetera, et cetera. But more or less the schedule is relatively similar for adults. It was really just about the COVID. Actually, it's the same for adults. They were just talking, it was really just on the COVID vaccine. These are all on the CDC website, by the way. And then this is the recommended child and adolescent immunization schedule. And I just put this up there because there's, so many vaccines that are available. And one of the things that was controversial that the CDC panel actually voted against was the MMR-V vaccine. You can see MMR in the middle there, and that's measles, mumps, rubella. That's probably the vaccine that's been the most controversial. I'm gonna get to that in a second. But to give kids fewer sticks, there's a combo that combines MMR and varicella, which is chickenpox. And there's a tiny risk. There's thought to be a tiny risk of seizures, a high risk of seizures to get the combo vaccine. The data actually doesn't play that out, but actually since 2009, that recommendation has been since 2009, the recommendation has been to give them separately because of that increased risk. And the ACIP just kind of went on, made that more of like an official recommendation. But generally, most kids get them separately. That's really mainly common practice. I think it's 85% of kids get them separately, and it's really just for convenience. They're both equally effective. The reason that the risk is a little bit higher is because there's a little higher dose of varicella in the combined vaccine than in the separate vaccine.
And they were originally combined just to do fewer sticks, but there's less compliance and we have more sticks, so.
Yeah, exactly, right. And it's just easier for the kid not to, the thing is less kid, less pain for the kid, so yeah. So this is the article that started a lot of issues. This is an article that was from The Lancet in 1998 by Andrew Wakefield, you may have heard of, who started a lot of this vaccine skepticism. Or actually, maybe gave it a little more legitimacy. This article was retracted, but only about 12 years after it was published. And what happened is that he had this study of about 15 kids, and this pervasive developmental disorder was seen as, as autism. And through this article, they were seen as a link between this vaccine and autism. But actually, the vaccine, first, like the aftermath of this article is that really obviously it never should have been published. That's why it was retracted. And also, you can see in the bottom here that he acted unethically and shown cause for disregard for the children in the study, in the way he did the study. So the way he did the study was really poorly designed. The way the data analyzed was really biased, and the findings were just totally were actually were false. Unfortunately, this was out there in the literature for a long time, and that kind of started the wave of the thinking. The more well done studies that are epidemiologically methodologically sound. I'm waiting for the slide to advance, but this is a study from the when it comes on. It's from the New England Journal. And here it is. Okay. So this is a population-based study from Denmark. And the good thing about the Scandinavian studies is that Scandinavian countries is that everybody's medical records are taken from birth. There's one huge database, so it's very convenient to do epidemiological studies. And so you can just see on the bottom that there's the study. It's an epidemiological study, so you can't prove causality, but you can prove that there was no evidence about MMR causing autism. This is one of many studies that have shown the same finding as well, but unfortunately, the misinformation is still out there. So that's one. That's about the MMR and autism. The second thing you may have heard of is thimerosal, which is a preservative that used to be in vaccines. And that's also been controversial as well, because thimerosal is a mercury derivative, and people are, for good reasons, are worried about mercury. But the issue with thimerosal is that the kind of mercury that is toxic is methyl mercury, and thimerosal is actually ethyl mercury. So even though it's a derivative, it's the type of mercury that doesn't cause toxicity. And you can see on the second bullet there, the toxicity concerns about methyl mercury, which have never been used in vaccines. The last thing is that in 2001, it was removed from all routine childhood vaccines as well. So, but even so, thimerosal, all the evidence has shown that thimerosal is safe, and again, mainly because even though it's a mercury derivative, it's a type of mercury that is not toxic. So this is another kind of false claim that's been out there about vaccines as well. And I think recently too, there was a vote I can't remember the CDC or FDA about thimerosal as well, which is kind of redundant because again, it hasn't been vaccines for 20 years. So what happens with vaccine skepticism is that you can see kind of the doubts that have been going on about childhood vaccines. This is a poll from the Kaiser Family Foundation and the Washington Post. And you can see here kind of what people are thinking about vaccines. For better or worse, unfortunately, there's a pretty large amount of people in the poll who are this is from New York Times, but what's happened is that actually as kindergartners as there's more vaccine skepticism, fewer people are getting vaccinated, and so you lose your herd immunity levels as well. So you can see we're already below the measles target. So that means in certain areas that we're below the herd immunity target. So that's why you see this measles outbreak happening. And it can happen with polio or whooping cough, Roach's pertussis as well. So that's really the fear on the public health level as well, is that fewer kids get or fewer people or kids get vaccinated. These vaccines come back, and these diseases come back, and you affect people who are most vulnerable to them as well, such as newborns who can't get vaccines or can't get vaccines.
Well, also immunocompromised people.
Yeah, totally. I mean, you name it.
You can get a vaccine as a child and then become immune compromised.
Totally. Yes.
And then
absolutely,
if measles is endemic in the population, you get it and die.
Totally.
So has there been a change over time did Kaiser look at the change over time in vaccine skepticism?
That's more, I mean, I don't know about the trend, but I would assume that as the with fewer people getting vaccinated, that must mean the skepticism is going up. But that was a cross-sectional one time.
One time.
Anyway, so this is what we just talked about. I don't need to go over that. The vaccine panel. This is like we talk about, skeptics or other words for the people that were on the panel. An example is this one, Vicki Pepsworth, who is an RN, but she's part of the National Vaccine Information Center. And that is basically a nonprofit advocacy group that advocates against mandatory vaccinations. So her views are probably on the extreme of people that are on that committee. But these are those when they say they added vaccine skeptics, this is just an example of one of the people who's a vaccine skeptic who's been added to the committee. This is kind of the other thing too, from when he was talking about the COVID vaccine schedule change, when people actually read his references that were in the paper that in the document that he sent, the references didn't exist, among other things. So there are a lot of issues with the letter that he sent to, I can't remember if it's to Congress or the CDC, but basically I think it was to Congress. The Congressional Committee asked for this information. And when they looked at the actual paper, it was, anyway, it was the references didn't exist. So that's kind of what's happening in that area. One other thing is the mRNA vaccines. So we were talking about that earlier. There are different types of vaccines, So for example, varicella or some MMR are live virus vaccines, which actually have the virus that are attenuated, so they can't affect you. There are other vaccines that are just parts of the virus, so those are immunogenic enough. mRNA is a different type of vaccine, and that's how warp speed happens so quickly. Is with these mRNA vaccines, is that it goes into the body and it actually helps your cells, create the protection as themselves. And mRNA is actually technology that's being used now for cancer vaccines, allergy vaccines, a lot of different types of technologies as well. And you may have heard that the administration has cut about $500–600 million of funding for mRNA vaccines, which is,
There's not a lot of longitudinal data on how this type of vaccine affects.
Well,
right?
let's see. So COVID was 2020, so we have 5 years of longitudinal data.
Five.
Yeah. So
and how, but that typically it takes a lot longer to get even through the trial.
It depends on that. Well, that for COVID it did, but what's happened that we have basically the largest natural history study of vaccines ever with the COVID vaccines, and the outcomes that we've seen are the protection of public health, those benefits are much higher than the risk or any kind of negative outcomes that are happening with COVID vaccines.
Wasn't mRNA actually discovered in 1960?
Yeah, it was in 1961, but it took a while to get the technology out there to make it into vaccines.
Was lying around.
And interestingly, one of the inventors of, I think he's one of the inventors of mRNA, has become a very big vaccine skeptic. Okay, and this is the compact that we talked about earlier, that are where the states are combining on the West Coast and the East Coast to just have these regional health allowances to not necessarily go along with CDC recommendations. And I think we spoke about, there was a question earlier about payments. So the American Health Insurance Plans, which is the trade organization of insurance companies, basically said that on the bottom here, they'll continue to cover all ACIP recommended immunizations that were recommended before the current changes. So most, if not all, health plans have agreed to continue coverage for vaccines, regardless of what is happening.
This year.
Through
the end of 2026. Yeah. So for now, yes. For now.
But there's still a gray area.
There certainly could be, yes. But,
well, there are companies that sell insurance.
Oh, sure, right.
So there are.
Yes, that's right.
So
but
people have to work harder to figure out
yes,
if they or their children are covered.
That's right. But Aetna, United Healthcare, all the big ones are covered. And then this is just one of the last things is about another strategy that may be happening, as well as there's the vaccine injury compensation programs. This is something that happened in the 80s. That is a federally funded program that basically takes, if there's ever a proven vaccine injury, this is how people get compensated. So the reason that was created was, one, there was, I think it was the pertussis vaccine, where there was issues with a certain batch of vaccine and people had injury from that. But the second reason is that vaccines are not big money makers. And so if companies who are making them are liable for them, they have less incentive to actually create them because, the profits could go away, particularly in the current environment. So if that vaccine injury compensation program is dismantled, that reduces a lot of the incentives economically for development of vaccines, and that could really hurt future vaccine development as well. So this is a speculation about there's nothing like that's happened yet, but this is just another possibility. This is just the last thing is about these are talking points from the American Academy of Pediatrics about vaccine hesitant patients. They're much more, I think it's a much better, probably a better way to say it than skeptics, but, listening to concerns, decision-making, talk about, and different ways to talk about it. So, I think I like the one from the fifth from the bottom. The idea that vaccines are one of the most significant scientific achievements of the past century. I think it's something good to start with. Anyway, so there's there are ways to talk to patients about that. So the science about vaccines, that they're safe and effective, but the evidence doesn't necessarily persuade people for a variety of reasons. This tailored communication may reduce skepticism or hesitancy. And the big issue about reduced vaccination is that it can reduce the public health effect among not only for people who may get the diseases, but the overall public health effect as well. One of the things that Ken had asked me about was, and Saralee had asked about excess, what would happen if people don't get access to the COVID vaccines? And there was, the first risk was not surprising, in high COVID, there's a huge, mortality benefit of giving COVID vaccination because, people were dying and mortality rates are huge. So the effect was obviously much higher back in the peak COVID, but currently it's, this is a recent analysis that looked just like a nationwide study about it, showed that it would prevent about 1,000 additional deaths in people over 65. So that's about 7,000 or 8,000.
That's right, speaker, that's universal versus high risk.
Yeah, exactly.
And that's based on the recommendations,
So
And
that's
also so many people are vaccinated.
so many people are vaccinated, but this is because that's also, this is also kind of like future. So
the short-term identifiable mortality rates.
Sure, yeah,
The long-term rates are still, we don't know.
Long COVID, things like that. And also this is a modeling study, this isn't an actual epidemiological study, right? This is looking at, rates, and this is just numbers. This isn't actually
When each time you get infected, you don't know whether you're going to get whether your course is going to be the same as the past.
Right. Yep. Yes, right. This is just
You
mortality.
want to avoid it.
Yes, you really want to avoid it.
It's just mortality. It's not anything. It's not.
Yeah.
Is there any, I know when my son was younger, my first son, not my second son, we could split apart the MMR.
Yeah.
Is that something that's,
I think
That's
it's the
gonna-
MMR is
that's
still a combo.
because we are in the
and-
pharmaceutical, it's like,
Ones, I think they're all.
It is.
yeah.
Yeah, I think it's.
From
what
what
I
I read, it
said,
didn't look like they were
it's
making
hard.
it anymore.
People
Yeah.
tend to like combinations, so
Yeah.
they don't have to do it.
Yeah, well, it's
Yeah.
3 times if it's MMR. Yeah.
It is responsive to the concerns. You still get all three of them, but you just get them 6 weeks apart, as opposed to in one.
Michael, in your practice, you just practice one day a week, Bellevue, are you seeing the effects of vaccine skepticism or?
What we see hesitancy, but it's much more for COVID than anything else. I think people are over getting COVID vaccines. And so I think, and actually you could make the case that the flu think it's still early. We just like this, the season just started, so we just started getting them, so we haven't seen it yet. But in the past, it really was just around COVID. And unfortunately, like I think the COVID vaccine hesitancy has drifted into other ones. So people, think about like, should I get the zoster vaccine? Should I get this? Should I that? And it kind of makes people more hesitant.
HPV too.
Oh, yeah. I mean, all of it, but
Totally.
it's there's you've definitely seen the uptake, and I think it's more of like the fallout from what happened with the vaccine.
Yeah. I would also think that it's not true, but people would have concerns about the cumulative effect of, like so many vaccines in the body. How do you counter that?
Yeah, I mean, you have to, well, it's hard to counter that because that's like it's a theoretical risk. And, you get, I mean, you can see like when we give kids vaccines, you give them, I can't remember, it's like 18 different shots or something like that. And it's worked, we didn't have polio, we didn't have measles, and we didn't have all these diseases. And there really haven't been, if you think on the population level, there really aren't side effects from it. So that's, there's always going to be anecdotal, unfortunately, there's anecdotal evidence of people or anecdotes of people who have a bad side effect or something like that. But, you can't, you have to think.
School.
Yeah.
School. And we couldn't let a child in without their vaccine.
Yeah, no, you can't now either.
Right.
Yeah.
And so I'm wondering
You get a religious.
what
Unless
they,
you have an
what they
exemption.
did, especially with migrants
With
coming
what?
in who
Migrants.
Oh.
migrants who may not have had any of these vaccines in from certain places. There's been no news about it, no reports about it. A lot of people.
They changed the rules.
They changed what?
They changed the rules. Either that or they gave vaccines.
Yeah, they might have given vaccines because you can do
I
blood
would
tests
think
and see if
so.
they're immune, especially.
Because they don't want those kids to get vaccines because then
They can't
you
test
lose
for
the
all
herd
those titers.
immunity to all that shit.
You can see, you can test if you're, you can test, or they may have vaccine records, or who knows,
Yeah. Thank you so
Thank
much.
you.
Thank you, really great presentation, sure.
It's certainly the topic of the year. What, I mean,
Well, I mean, except not.
Except all the other topics.
You said people are over to getting them, and it's true. I think there's the compliance is, I mean, I don't,
well, but with that,
uptake incidents, people taking them is, even if it weren't being barred by
but
policy.
without, I mean, being too partisan, the conference, that President Trump and had the other day, in which he went on a rant about Tylenol.
Mhm.
Yes.
That was very
I've always known Tylenol was dangerous.
Pardon me?
I've always known Tylenol was dangerous.
I mean, that was very harmful. Imagine if you were a pregnant woman now and you had
Yes.
taken that.
Yeah.
Like, so we should talk now before everybody has to go.
Yeah.
About going forward, how we're going to, Ken and I were talking about the fact that we would like to encourage the people on the committee to offer suggestions about presentations that they would like to see.
I have one.
Hold it.
Okay.
And we will, see, Shelley's so good on the
Mhm.
But we would like, because if it just comes from Ken and me and we're having these ideas, they're gonna be pretty much similar because we talk about these things. But we would like, Shelley's, what is your?
So I saw a presentation the other night. I'm on the community advisory board for Mount Sinai West
Yes,
and Morningside. There's a relatively new thing, which is virtual, I call it the virtual urgent care. okay? Where I don't want to give it all away. So I'm sitting here and someone says, oh, you have a bump on your hand. Oh, yeah, it doesn't look good. You take a picture of it or you can show it on virtually, you go on the system and they will in a short time have a doctor respond. And you're going to need a cream, an ointment, a medicine or something that they can assess. They will order it and they'll have it delivered to you. It avoids going out to urgent care and it avoids going to emergency rooms. And it provides for people who want to be at home or who don't think, they want to know if they have an urgent situation, a wonderful opportunity, and it covers a whole slew of non-life threatening and serious illnesses. And I have a contact from the person who is the spokesperson for it. And I said to her, would you be willing to come to community board HHS meeting? And so we could probably get her. if you'd like to. I think it's an interesting.
So it's a telehealth provider or
It's different than, telehealth.
Yeah.
Because you're sitting at home
Mhm.
and you're coughing, okay, but it's not severe. You want to get a sense of what's going on and you want to consult. And you can consult and then decide if you need to do something more by their recommendation.
So it's
And
like,
if there's something you need that is not, a serious medication or a serious treatment, they will order stuff. Or if you need an X-ray and MRI from what they can assess, they will make the appointment for you at one of many locations, some very relatively near. And to me, it's such a great thing, and people don't know about it. They said that it's been available for a while, and I said, another case of it's great, but nobody knows about it.
That's right. So what
Shutdown
about health
happens,
insurance?
actually, yeah, if the shutdown happens, that telehealth is not gonna be reimbursed.
yes.
Actually,
they're very-
that's a big
Yeah,
issue.
because you
Okay.
can't even do that without having all of the data.
That's
Yeah,
true.
yeah.
They have a certain allocation, so they feel they can do a lot even
Right.
then.
By government payers or by?
By Medicare.
Oh, okay.
Yeah.
Well, but if the government shuts down, it's not gonna be more than a month and a half. I mean, it's never been.
So just hold your problem for a
So-
month.
24 hours.
But this is an ongoing program. This is a program.
Oh,
You-
yeah.
You want us to know about the program.
I
not
think
for-
we need to publicize it,
Right.
and have people understand and ask the questions they need to ask.
But it's not CVS or anything, it's a different type of,
Right, it's something-
brand, some
right,
provider. of-
right.
But this is, tell me how. You have
Guys, sorry to interrupt. I need to jump off, but I will follow up Ken and Saralee with some ideas after. Sorry, guys.
You're jumping off land safely.
Enjoy the baby.
Thanks.
Okay. It just seems to me it's very good in a limited situation of maybe, if you have a lump,
Mhm.
it could be anything. It could be a bee sting or it could be.
Right. But they can tell by.
You know, and they can-
Visually, they can tell
With
visually.
AI,
They can.
they can tell.
Oh, yes.
Can they do?
They say they can. They say they don't want anything involved with personal parts, online.
We could probably triage it and say, if we can diagnose 80% of it, and for 20%, you have to come in.
Exactly.
That's
But if, say if you have some marks on your leg all of a sudden, I saw someone today, I was visiting, who needed, someone who needed a friend. And he had a bathrobe on and there were these dots all over on the bottom of the leg. And I didn't want to bring it up because, he wasn't there to show me his leg, but just the way he was sitting. So I said, have you looked into, small things? He had big issues.
No,
okay?
I understand that. My only caveat on it, having spent too much time in emergency rooms, is that you might not, it might delay you getting a full examination
Right.
from a doctor because
they-
there is something that is
They will tell you if they think you need more.
Yeah, right.
Okay?
Mhm.
But
But even Amazon does stuff like this now, right? I mean, I literally, you can even go on
They
Amazon
do?
Care, Amazon, yes, even, there's a ton of
Yeah.
providers that do this type of work.
Yeah.
It's not novel
I
anymore.
more trust.
It's
That's
exciting,
scary.
that, yeah, exactly, you trust your
not
person,
signing
yeah.
over there, yeah.
But you can even go on Amazon and have a telehealth appointment.
Really?
Yep,
Yeah, and they'll deliver.
and
it
they'll
out.
deliver it right to your door. By
Well, I mean,
5 p.m.
Deliver a cure.
Yeah.
By 5 p.m. So this is.
Well, this is a great idea.
Did I make?
Yeah, you should,
Yeah.
All right.
but you
More
don't.
But
ideas.
it's great for
More
people who are
ideas.
homebound, it's great for
Oh,
people.
no question, and
you know,
people who are hesitant to
People are
go to
hesitant to
doctors, I know
go,
many of them,
sure.
they'll hold back and hold back,
Sure.
and then something comes more serious.
But you don't necessarily, like Shelley did, what, I mean, with the committee, we're looking for ideas. You don't necessarily have to have somebody in the wings ready to come present like Shelley does, but, you know, we're
We would like,
looking for ideas, and I think you and I talked about
We did,
doing
yeah.
something, and I'm gonna talk to Isaac.
Yes, Isaac would be the right person, and I think that there's two pieces, that the street homeless population has really grown, even in the last couple of months, because I was, you know, and that is different. I've been working in homeless services for almost 2 decades here in New York City, and also serving this particular community. It has changed demonstrably just in the last few months, and I think that there is a change, that there's some encampments that have been disbanded downtown, which could have moved people. I also think Isaac will know too, that there's some of the breakfast lines, like at my church, for example, you know, are robust, but they also have closed their shelters because of because some of the new regulations for the housing that the Department of Buildings put on. So it did change some of the way that people are accessing services. So more people may be hanging around during the day, and then, you know, or having to go someplace at night because they can go to the breakfast lines, but they can't stay overnight, you know,
Okay,
so.
This committee advocated, and the board
Yeah.
did, for a safe haven on 83rd Street.
Yeah.
And 2 people who I've seen regularly are now there.
Yes,
Okay?
yes, yeah,
And I was about to
That's
tell
great.
one of them, you know, you can do it.
we live on 82nd, so I
And-
know what's there.
And he said, I'm going to 83rd Street. I said, and what's on 83rd Street? Oh, I'm gonna have a place to stay, and by the way, the funny thing is, after certain people vehemently opposed it because of A, B, and C, and the 3 most angry people called me 6 months afterwards and said, when are they opening the safe haven? And I said, 6 months
So
ago.
go, yeah, I agree.
Well, all the years
It's gonna
they
change
had,
everything, yeah.
why aren't there problems in the street? Why aren't there?
It just has changed, but I think
Yeah, but
I think there's a couple problems,
is
and I could
increase.
put something together, a little like
Good.
outline
Good.
I really want to understand, I'm sure Isaac will have an understanding, like, of why, what are some of the policy changes in other places that have changed? You know, that have bringing people to more beyond the street as opposed to accessing different shelters. There, we used to be able to readily call, you know, like Bowery Residence Committee, because they did the homeless street outreach. Those are not services that are really accessible. They're not being used anymore, and the contracts are different. And how does one engage someone now, or how do you call? You know, we live right across from the precinct.
These municipal contracts, city contracts that you're talking about.
Yeah, there were street homeless outreach contracts. There are a street homeless outreach contract, and you used to be able to pick up the phone and call my, you know, one of my colleagues and say, yes, she's sitting in front of Starbucks, will you please come? And it used to be just a different environment, for that to be a possibility. Now we have just such a different political environment, different environment altogether. But when someone is struggling, or when someone is regularly in a particular place or moving on the street, which I've seen myself with, you know, moving within our street, we live by the precinct, so I'm sure it's safe. But I'm not talking about one person, I'm talking about a number of people who have come into the neighborhood who are staying.
And you said moving, like moving to stay.
They're just physically moving,
Okay.
you know, you see them there, and then you see them. I know that they're in supportive housing, or they're in, you know, I know, but then there's also a very new group of people who are really suffering that is new to the community. And we in the Upper West Side don't see it as much as other areas, but that's changing. And I'm just kind of wondering, you know,
And people who are, well, only walk Broadway, don't see the people who are in Amsterdam. They say,
yes,
"Oh, I only saw 5 people,
yes.
and there are 18
Yes.
there."
Yes,
You know,
we've lived in the same place for 25 years, and I've seen a demonstrable change in the last 6 to 4 months, 4 to 6 months.
What do you think?
I think some of the changes in the
Mhm.
encampments, I think
Oh, something-
downtown, I think, yeah, I think that, but there are there are resources, there are some, you know, who knows how that will change, you know, and if there are resources in the community, making sure those connections are happening. And Isaac would be actually, but he knows that has been some changes because he runs a shelter and he also runs faith-based shelter programs as well. He has a good sense of that. And so we've lost some of our shelters that are the overnight temporary, that people leave and then come back.
So on a positive note.
We may be able to re-engage because I think
uh,
it's returned back to the old regulations. It's changed.
That's tomorrow at 12 o'clock.
Yes.
There will be a celebration on 106th Street.
Yeah, right, I was gonna just say that.
Okay,
Seema-
please.
No, you.
Oh,
can
is
do
there
it.
the
Okay.
opening?
Seema
Yeah.
said that.
That this committee facilitated with the community by bringing our meeting up to 106th Street, so that the block association, all the tenants groups and the residents could be there and confront the Department of Homeless Services on why they weren't being given information, why things were happening. And with the challenge in that meeting, it was incredible. What we had asked for in our resolutions previously, that community advisory boards for new projects would start 6 months before it opened, with the idea that why wait till it opens, then 2 months or 3 months later have a community advisor with all the complaints? Why not work out the problems beforehand? And sure enough, the 106th Street Women's Shelter.
Right, but they didn't initiate the community advisory
But they
board
did
in
meet.
advance. I got a
Okay,
couple
go
of
ahead.
calls
Sure.
from people who requested that the community board
Right.
invite the city
Mhm.
to a big meeting to encourage them.
No, it always was the city policy.
But now,
That's terrible, that we thought there was finally a breakthrough.
right, no,
But the beautiful thing was that 107th Street, we physically demonstrated when they were trying to close the women's shelter and did. And Project Help, which was the one that was running that one, this is going to be the women's shelter. It wasn't supposed to be,
right,
but it's a women's shelter on 106th Street.
106 and
Between Central Park West and Manhattan Avenue.
we have been trying to work with the city on coming to our meeting
They're very,
and having, they
Yeah.
don't want to be yelled at, they said.
Yeah.
But so tomorrow is a celebration.
tomorrow, I just
Right.
received something today,
Right,
and
I'll forward.
We didn't get.
Is it a grand opening?
I got it.
I don't know.
I also want to flag that Seema has her hand raised.
Seema sent it and I was gonna send it. Oh, hi, Seema.
I
Seema,
I can send it around. Sorry, I didn't know who was on the HHS committee, so I didn't know who to send it to. I just wanted to say I wanted to really give a shout out to your committee because I think it was because of you, led by Shelley at that point, that so much progress has happened at that shelter. When they came to talk to us, it really did feel like we were talking to a brick wall, but it turned out they were actually listening. They completely changed the program, and now it's a women's shelter, which is exactly what the community had asked for. And it seems like it's working well. So I encourage anyone to come. There's an open house, 12 to 2 p.m. tomorrow at the the shelter, which is at 106th and Manhattan Avenue. There's also one other event that your committee might be interested in, which is a sort of a ribbon cutting happening at the Lincoln, what is it? The Lincoln Center.
Neighborhood Center.
There you go. Thank you so much. Lincoln Square Neighborhood Center on Friday, October 3rd at, I think it's 11 o'clock. No, 10 o'clock. 10 o'clock. And they've just completed some, through Goddard Riverside, some projects to increase the ADA accessibility of the site along with some other improvements.
Thank you.
So what topic would it be? Like, is it like having Isaac talk about it? Is it about having people, I don't know, from Department of Homeland Services?
Well, we
I
talked
can't
about having you and Isaac sort of co-present.
Yes,
Um,
yes.
But we
I'm
need
sure
to
he has
refine
a
what.
better understanding of what the recent policy changes may be. But yes, we should investigate and learn. And I think also, what is the step? I feel like I really had a handle on what the step was. You know, make the call, do the outreach, and now I don't really have a handle on what the step is, despite having experience,
Right.
because it's changed so much. And I haven't been working in the city for a number of years, and I think it will probably change again in 4 months. So, yeah, it'll probably change again. That's what I meant. It's like, I don't know, and then it's gonna change, but we should know.
Yeah,
You know,
totally.
I should know. I don't know anymore.
So one other thing we need to talk about before we leave is the technology. As you might have noticed, it's not foolproof. And things, so tonight we were lucky to have Alexandra Crawford, who's the Deputy District Manager. I think that's her title. something like that, to help us, because she's, been trained in this, but going forward, we're not going to have people like Alex. We're not going to have staff members. We've had staff members up until now. But the problem is that the union that represents them, this came up in steering 2 weeks ago. But there are two kind of pots of money, or not pots of money. There are two ways of reimbursing staff members for doing extra work after hours, and one is called voluntary overtime, and the other is called mandatory overtime. And voluntary overtime, you get reimbursed. You can get reimbursed with time, so it's like comp time. But mandatory overtime, you got to get paid cash. Money. So the union told us that we've been using the voluntary overtime. We can't do that anymore. And so if we continue at the level that we've had, where we have all committee meetings, with having somebody like Alex as a tech person helping us, it's going to break the bank. We're getting where it's going to run out of money fast. So
we should put it in district needs.
No, we
yes,
are.
we can do that,
That would be very nice.
but we can either, we have two choices. We can either decide we're just going to be in person as a committee, and I can tell you the electeds wouldn't be all that thrilled about it.
Too bad.
As you can see,
They're lucky they're elected.
They don't,
They don't want to come in.
it's much easier for them to
Right, not
participate.
very effective.
Well, and the public, and the public,
And the public, and people like Michael, who just had a baby, couldn't be in the meeting. Or we can take over the tech ourselves. And Saralee and I are trying to get trained, but they've also recommending that all committees talk to their committee members, and it's too bad Michael isn't here because I think he's kind of tech savvy, but try to identify people,
Who
one
are
or two
would
people
like
on the
to do it.
committee who are
Who are
very tech savvy
able to do
and
it.
concerned.
Yes,
We have the most tech savvy person probably on the board.
Who?
Will.
So where's Will?
But he's not on this committee. We're
He
grateful
is
that
on
he's
the
here.
committee.
Oh, my
He's on
bad.
the committee.
I
Will's on the
apologize.
committee,
Will,
but he's not
did you
looking
hear
up.
this?
Will. Are you
Yeah.
there?
I can hear you.
Okay.
I was just saying.
It keeps
that-
cutting. it keeps cutting in and out, so it's really hard to pay attention.
They're saying that you're probably the most tech savvy person that we have on the board, let alone on the committee.
So we were trying to figure out, going forward, if the staff can't manage the equipment, the audiovisual equipment, we need to ask somebody who's on the committee to volunteer to help us out to do it. Because although Ken and I are willing to learn, we haven't been great students. I in particular am a Neanderthal, but could we ask you to participate?
I would love to. I would love to, and would have a wonderful plan of action on how to make sure not just our committee would have a great plan and support all committees, but that's another story for another day.
Okay, well,
what we're looking for, what every committee wants is a chief information officer for their committee.
oh, that's title.
So I think we
CIO.
I nominate Will as our CIO.
I second.
Fantastic.
Does he accept the
You
nomination?
accept the nomination?
Seema has her hand raised.
Yes.
I just have a suggestion. Louisa and I were leading a committee meeting last night and trying to handle our own tech, which, I think it was Jesse and Maisie who got us started, which was fantastic. So the meeting, short of the Wi-Fi glitches, went really well. The big suggestion I'd have, it really can't be just one person. Ideally, it's not the person running the meeting, but ideally two other people, one person to monitor hands raised and another person to monitor what's going on in the Q&A. Because it's hard for one person to do all those things and still engage in the meeting. So that's what I would love to do at Land Use as well, is to try to identify a couple of people who can rotate through and just, answer questions as appropriately and also make sure we're not missing hands that are raised.
Great. So maybe Ken and I could talk with Will on Zoom or something and set it up, and he can tell us what he needs.
Yeah.
Is that okay with you?
That's your first test, is to set up the Zoom meeting.
Yeah. You know what I'll actually do to make things a lot easier? I don't know what your day, like what your 9 to 5 availability looks like, but I can send you my my work Calendly when we could book a time for all of us to chat together. So I can just allocate some time for us, so we can make that a reality.
And then I like Seema's idea.
Yeah.
Of we're going to need one.
But then we have two
volunteer.
people doing it. Their attention is drawn away from the substance of the meeting. That's a problem.
Right.
Anyway, we'll figure it out.
One thing that Beverly mentioned was we're no longer doing minutes. And there used to be, back in the old days, every meeting you had to pick somebody to take the minutes, and that took your attention away big time. Now we don't do that, so.
Now we just do hours.
What?
Now we just do hours.
Oh.
Is Max?
But the text center is difficult.
Yeah, Max will be replaced.
Okay, he will be replaced.
Yeah,
Okay.
there's gonna
Because
be.
he also provided a lot of technical
Yeah,
support.
Sure did.
And so that will be coming back online
Yeah.
for every meeting. Okay.
No, whoever the district manager is, it's the same thing. They would have to be paid out of mandatory overtime. So
But it
we
wasn't-
couldn't afford it.
But he, wasn't his role to come to all the meetings, so it's not?
I think he's part of the union, Alex, and it was the same issue, right?
Is it?
I don't know.
I think.
We'll find out.
Interesting, yeah, because that makes a big difference, actually.
Oh, yeah.
It makes a huge difference.
Oh, yes.
I mean, the biggest problem is when you have a snafu like we had with the audio. And like, what do you do? I don't know what Alex did, but
You know where the word snafu comes from?
Yes.
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 Situation
Yes.
normal, all
What's the
effed
Say
up.
it again?
Situation normal, all effed up from World War II. But unfortunately, it sounds like the situation normal is that our audio does cut out. Like that, it sounds like Will is telling us that the audio issues weren't really fixed.
Right.
No No shade
You
on it.
guys both freeze and also cut out.
Yeah, it was mostly freezing that was happening,
Yeah.
so.
But it looked like it was just Wi-Fi issues. It wasn't like anything that we could control unless you
I
get
don't
a stronger router or something in your.
Well, or the provider.
Yeah.
Is it Spectrum? Is it?
Yeah, it's something we're working on in progress because there's numerous networks. So we're trying to figure out how to really troubleshoot that moving forward. Because we had the internet provider come a few weeks ago, so still in progress.
I've heard we don't have, or there have been some complaints about the internet provider.
So is Barclays.
Green, yeah.
What?
Okay.
Oh, we got a boost. We got a boost.
All right.
Everybody.
Motion to adjourn.
Have to go.
So moved.
Second.
See you.
Next meeting.